So, if you think about it, during a normal delivery, the levator hiatus, which is, the muscular opening in your pelvic floor, it has to undergo this level of stretching that would literally rupture pretty much any other skeletal muscle in the human body.
Right, it's a massive, massive biomechanical event.
Exactly. It's astonishing. But then, someone walks into a clinic, maybe months or even years later, and they're reporting that they feel like loose or unsupported or just structurally changed down there.
And they just hit this absolute wall of diagnostic confusion.
Yeah. Or, like, even worse, they get handed a generic pamphlet on Kegel exercises and are basically just sent on their way.
Which is so frustrating because we are looking at this diagnostic landscape where the medical language actually betrays the anatomical reality.
Oh, totally.
Both healthcare providers and patients are constantly mislabeling these fundamental tissue changes as organ descents. And that leads to treatments that just do not match the underlying mechanics of what's actually happening.
Right. So let's just set the stage for today's deep dive for you, the listener. We're looking at a pretty formidable stack of sources today.
Yeah, we've got NHS trust documents, academic reviews from the RCGP, some really specialized surgical center, FAQs.
And comprehensive clinical guidelines, right? So our sole mission today is to untangle this massive conflation between the sensation of, quote-unquote, feeling loose and the actual medical diagnosis of a prolapse.
Exactly.
And we're going to definitively answer one specific question right out of the gate. Can a gaping vaginal opening occur entirely without a prolapse?
And the unequivocal answer from the clinical literature is yes, absolutely yes.
Wow.
Yeah. Gaping at the vaginal opening can and definitely does occur without any prolapse. I mean, they are entirely distinct anatomical phenomena. They just happen to share, the same zip code in the body.
Right. Because I think our audience generally knows the basics of pelvic organ prolapse by now, right?
Yeah.
Your cystoceles, your rectoceles.
Standard structural failures, yeah.
Right. Where an internal organ physically drops down into the vaginal canal. But what really stands out in these sources is how frequently the actual sensory change of vaginal laxity is completely misdiagnosed.
Oh, it happens all the time. A doctor will use the standard POPQ system. That's the clinical tool used to measure organ descent.
Right.
Basically, they are hunting for a hernia-like bulge. And if they don't see an organ protruding past a certain point, they just confidently tell a patient that everything is completely normal.
But they're looking for the wrong thing because laxity, which is the primary driver of a visibly gaping vaginal opening or introitus, it's actually a loss of tension and structural volume in the tissue itself.
Yes, exactly. It is not an organ descending due to gravity. The clinical implication here is just massive.
Because you could suffer from severe laxity, like a really gaping opening with absolutely zero measurable prolapse on a chart.
Right. And conversely, a patient could have a measurable prolapse on their clinical exam without feeling any localized sensation of looseness at all. They're two different metrics.
So, the University College London Hospital source actually inspired a really great way to visualize this disconnect.
Oh, the hammock analogy. I love this one.
Yeah.
Oh.
So imagine the pelvic floor is this highly engineered hammock. Right? And it's supporting your internal organs.
Right.
A prolapse is basically what happens when a bowling ball is dropped into that hammock. It just aggressively drags the mesh downward.
Exactly. But laxity, on the other hand, is the hammock material itself being permanently warped and degraded.
Yeah, so like the intricate weave is literally pulled apart. The individual fibers are all frayed.
Yes. So there is no bowling ball. There's no heavy weight sinking down in the middle. But the hammock is still hanging wide open because it's completely devoid of tension.
Right, which means if a healthcare provider treats a stretched out, degraded hammock by assuming there's a hidden bowling ball causing the issue.
The treatment pathway just completely derails.
Totally. The patient is told they're fine because the specific metric the doctor's looking for hasn't been met.
Which just leaves the patient to manage these really profound disruptive symptoms entirely on their own.
Which is wild. So if there's no organ pushing down, we really have to look at what physically destroyed the weave of the hammock in the first place.
Right. And the academic reviews point directly to vaginal childbirth as the primary structural disruptor here.
But the sheer mechanics of how the levator hiatus actually fails they are way more brutal than simply stretching out, aren't they?
Oh, absolutely. To really understand the failure, we have to look closely at the biomechanics of a delivery.
Okay, break it down for us.
So the levator antemuscles aren't just this passive passageway, right? They actively support the pelvic organs against constant gravitational and abdominal pressure.
Right, they're always working.
Always. But to allow a baby to pass, these muscles have to face unprecedented distension. The RACGP data reveals something really striking.
Yeah, the statistics here were shocking to me.
Right. In 10 to 20% of first-time mothers who experience a completely unassisted, normal vaginal delivery, the muscle doesn't just stretch, it sustains major trauma.
And frequently resulting in an avulsion, right?
Yes.
And an avulsion meaning, just so we're clear, the muscle literally tears entirely off its insertion point on the pubic bone.
Yes. It physically detaches from the skeleton.
I mean, a major muscle tearing off the skeleton during a routine physiological event is just a staggering reality to process.
It is. And the numbers become even more alarming when medical interventions are introduced.
Like forceps.
Exactly. With forceps deliveries, major avulsion trauma occurs in 30 to 65% of cases.
Wow. Over half the time in some samples.
Right. And then when you compound that avulsion with episiotomies, those surgical incisions made to widen the opening.
Oh, right. Or even severe natural perineal tears.
Yeah, those heal with this rigid, thick, inflexible scar tissue. So the structural foundation of the introitus is permanently widened. The whole architecture just fundamentally collapses.
Wait, hold on. Let me jump in here. Because I'm looking at the Women's Health Clinic source. And it specifically notes this very common piece of advice, right?
Oh, about sexual activity.
Yeah. It says that regular sexual activity does not loosen the vagina because the muscle is inherently elastic. It's biologically designed to unfold and expand.
Right.
So I'm kind of stuck on this contradiction. If the tissue is engineered for this extreme elasticity, why does a delivery cause permanent gaping? Like, why wouldn't it just snap back into place eventually, the same way it does after other activities?
That is a really great question, and it's a super common point of confusion. But you have to separate normal physiological relaxation from catastrophic mechanical trauma.
Okay, so arousal versus injury.
Exactly. So during sexual arousal driven by hormones, the vaginal rugae, those complex folds of tissue lining the canal, they naturally smooth out and expand.
Right.
They are perfectly designed to return to their baseline state without losing any tone. That is a physiological response functioning entirely within the normal tensile limits of the tissue.
Okay, that makes sense.
But childbirth, however, far exceeds the maximum tensile strength of that fascial and muscular support system.
Oh, I see. It sounds like kind of like the difference between pulling a heavy-duty bungee cord to its rated weight limit, right, versus just dropping an anvil on it.
That is a perfect analogy. Yeah.
Right, because the anvil just completely snaps the internal elastic fibers.
Right.
You might still have the nylon outer casing intact, so outwardly it still looks like a bungee cord.
Right. But the internal retraction mechanism is completely destroyed.
It's never snapping back.
Never. The structural integrity is permanently compromised. And, beyond that acute singular trauma of childbirth, the sources point to these insidious cumulative factors that degrade the tissue over decades, too.
Right, like menopause.
Exactly. Menopause triggers a massive drop in estrogen, and estrogen directly dictates the body's collagen production.
Ah. So without adequate collagen, what happens to the tissue?
The fascial tissues basically thin out. They lose their natural plumpness, hydration, and overall volume. The tissue literally physically shrinks and weakens.
Wow. And the sources also emphasize chronic straining, right? Particularly long-term constipation.
Yeah, pushing us into what is known clinically as descending perineum syndrome.
Which is a fascinating, albeit pretty grim, mechanical process. I mean, decades of increased intra-abdominal pressure just bearing down day after day on the toilet.
Right. It constantly forces the perineal body downward. It essentially forces the connective tissue to yield and permanently stretch out over time.
So when you actually understand these biomechanics, right, the avulse muscles, the severed internal bungee cords, the severe collagen depletion.
The daily symptoms stop sounding like minor inconveniences, don't they?
Absolutely. They reveal themselves as these really profound losses of functional autonomy. We aren't just discussing some clinical measurement deviation on a chart anymore.
No, we are talking about a fundamental breakdown in how someone physically interacts with their environment every single day.
Yet structurally, the gaping introitus just can no longer maintain a seal. Like one of the most common daily manifestations mentioned across the clinic FAQs is simply the inability to retain tampons or menstrual cups.
Right, they literally just slide out. Because that anatomical narrowing that should naturally provide grip is entirely gone.
Which, I mean, that alone is a massive disruption to a person's functional autonomy, just trying to manage your period.
Completely. And the loss of that seal also exposes really delicate internal tissues to continuous air exposure and clothing friction.
Ouch. Yeah, that leads to chronic vaginal irritation, right? And microabrasions.
Exactly. And just a persistent, really distracting sensation of being physically unsupported. But the sources also highlight an intimacy symptom that carries just immense psychological weight despite being medically harmless.
Vaginal wind.
Right. Frequently referred to as queefing.
Yeah. Because the introitus is widened, it acts almost like a vacuum, right? It
Yeah.
physically traps air during movement.
Right. Whether that is during intercourse, a yoga class, or honestly, just shifting positions in a chair.
And then when the body moves again, or like the core engages, the trapped air is expelled audibly.
And the surgical center documentation notes that this specific symptom is actually one of the primary drivers for patients actively seeking surgical intervention.
I believe it. The sheer unpredictability of it creates intense anxiety.
Oh, the embarrassment becomes paralyzing for a lot of people.
Right. People stop attending Pilates classes. They completely avoid intimacy. They alter how they sit in public spaces just to manage the risk of it happening.
And when you couple that with the loss of physical friction, which leads to severely decreased sensation during sex.
Or the active, searing pain of rigid scar tissue from a poorly healed episiotomy. I mean, the psychological toll is just immense.
It really is. And this is exactly where that disconnect between the patient's lived experience and the clinical diagnosis just absolutely peaks.
Oh, definitely. A patient describes this whole constellation of life-altering symptoms, and the provider finding no measurable prolapse on their chart.
They dismiss the concerns as purely cosmetic.
Which is infuriating. The idea that losing the ability to manage basic menstrual hygiene or, withdrawing from physical activity out of sheer humiliation is somehow a vanity project.
Right. It's incredibly dismissive.
It completely ignores the functional reality of living with compromised anatomy. Which I guess brings us to the interventions.
Yes. What do we actually do about it?
Right. If a patient is dealing with this severe structural failure, what is the actual medical solution here? Because the universal prescription for absolutely any pelvic floor issue seems to be just go home and do more Kegels.
Well, pelvic floor muscle training, or PFMT, is always the conservative starting line. And ideally, it should be done with biofeedback to ensure you're actually engaging the correct muscle groups.
Okay, but we have to acknowledge the hard physiological limits of what a Kegel can actually achieve, don't we?
Yes. Kegels target active muscle function. They build muscle tone, and they improve neural control.
But if the muscle is physically detached from the pubic bone,
A Kegel cannot reattach an avulsed muscle. It just can't. It cannot generate new collagen to replace lost tissue volume in postmenopausal patients. And it absolutely cannot stitch overstretched, torn fascia back together or somehow dissolve thick, painful scar tissue from an old episiotomy.
okay, imagine tearing a major ligament in your knee.
Right. Ooh, good comparison.
You could do leg extensions until you collapse, and sure, the quadriceps muscle will certainly get stronger,
Right.
but the joint itself remains fundamentally unstable because the connective tissue holding the whole skeletal structure together is shredded. Lifting weights doesn't magically weave a torn ligament back together.
It really doesn't. So when conservative therapy hits that physiological ceiling, the sources pivot to surgical reconstruction.
Okay, like what specifically?
Specifically, procedures like perineoplasty or perineorrhaphy.
Perineorrhaphy. Say that 3 times fast.
Right. But it's important to note this is not a simple tightening procedure aimed at aesthetics.
Oh, definitely not.
It is a really complex functional restoration of the perineal body, which is that critical mass of fibromuscular tissue sitting between the vagina and the anus.
So the surgeons are essentially going in to reconstruct the structural failures we mapped out earlier. They're rebuilding the hammock.
Exactly. Rebuilding the hammock, they excise the painful, restrictive scar tissue that is causing dyspareunia or, pain during intercourse.
Right.
They then locate the separated, damaged muscle layers and the compromised fascial support, and they physically approximate them.
Approximate meaning.
Yeah,
Bring together.
Yeah, they surgically bring them back together to reconstruct that natural support bridge. And this inherently narrows the widened introitus right back to its pre-trauma anatomical state.
Which restores the seal.
Exactly.
It permanently stops the air trapping, eliminates the chronic friction against your clothing, and reestablishes the actual functional friction necessary for intimacy.
It is a highly specific structural repair for a fundamentally structural problem.
Right. It addresses the root mechanical failure that physical therapy simply cannot reach.
Yeah.
So let's lock down the core takeaway from this whole stack of sources for you today. Gaping at the vaginal opening is a primary symptom of laxity, which is a severe stretching, tearing, and volume loss of the tissue itself.
Right. And it can, and does, entirely occur without pelvic organ prolapse.
They are separate conditions driven by completely different mechanics, and they require completely different diagnostic lenses and treatment pathways.
So if you are out there navigating these symptoms, you really must advocate for a precise diagnosis. Do not accept a blanket reassurance from a provider that your prolapse exam is clear when your daily functional reality tells a completely different story.
Absolutely. Your symptoms are real, they are rooted in documented biomechanics, and they are not a matter of vanity.
Well said.
Now, before we wrap up, there is this fascinating thread buried super deep in the clinical sources that entirely reframes how we think about pelvic floor health overall.
Oh, I know exactly what you're talking about. The mind-body connection.
Yes, we've focused really heavily today on massive, acute physical trauma, right?
Right.
Like childbirth or the sudden hormonal shifts in menopause.
Right.
But the literature explicitly states that, quote, psychological factors can amplify physical vaginal looseness,
Right.
and that chronic straining creates this feedback loop of worsening physical symptoms over time.
The mind-body connection here is intensely structural. Background psychological anxiety directly influences the resting tone of your pelvic floor muscles.
Oh,
And chronic daily habits like aggressive straining during bowel movements exert a slow, relentless physical toll on the perineum. It's micro-tearing the fascia day by day.
Which just leaves you with this haunting realization about the human body.
Yeah, it really does.
If our background anxiety and our quiet daily bathroom habits are directly degrading the structural integrity of our connective tissues over decades, how much of our long-term physical health is actually dictated not by the dramatic singular events of our lives?
But by the invisible, unconscious behaviors we repeat every single day.
Exactly. It really suggests that our anatomy is a living, shifting record of our daily habits, not just some static reflection of our major medical history.
That is exactly right.
Definitely something to think about the next time you catch yourself rushing through your morning routine. Thank you so much for joining us for this deep dive. We'll catch you next time.